Good morning, everyone. Can I ask you all to take your seats unless you're one of our new non-federal members? The new members, we'd like to invite you up to the stage for swearing in. For those watching online and those in the building, thank you so much for joining us today. It's hard to believe we're here after a tumultuous year already. We're so pleased to be welcoming you all to our first meeting of the Advisory Council on Alzheimer's Research, Care, and Services in 2026 with a new cohort of members and a packed day to learn more about the work that we've been doing. So I invite our non-federal members who are new to come up on the stage for swearing in. Don't be shy. Come on up. And I'll turn it over to Greg Stewart from OHR, who's going to be leading the swearing in.
Good morning. Oh, honey, you. Oh, thank you. Do I have all the new members here? Can everyone hear me? Yeah, does everyone hear me? I'll turn it to the side a little bit. How was it? Okay, great. If I can have everyone raise their right hand and repeat after me. I state your full name. Do solemnly affirm that I will support and defend the Constitution of the United States against all enemies, foreign and domestic, that I will bear true faith and allegiance to the same, that I take this obligation freely without any mental reservation or purpose of evasion, that I will well and faithfully discharge the duties of the office on which I'm about to enter. So help me God. Congratulations, you're all now officially appointed.
Good morning to everyone. We are so excited to have this Alzheimer's advisory group here. Thank you to all the new members. Michelle, thank you very much for agreeing to be our chair. And Dr. Randall Bateman, thank you again for deciding to come back and join us. I am Cindy Goss. I am the Acting Assistant Secretary for Planning and Evaluation. I am 1 week into this acting position. I am actually the Deputy of Planning and Evaluation Health Policy Lead. To those who do not know ASPE, just wait, you're going to know ASPE. This year, 2026, is going to be the shining year not only for HHS, for Secretary Kennedy, as well as Deputy Secretary O'Neill and President Trump. It is truly going to be an exciting year. And I look forward to hearing all about the great things that you do here at this advisory board meeting today. Let me breathe for a second. As you are aware, policies, they're difficult at times. So you're entering into a difficult policy, solution-driven organization. So what I would like to say is that welcome again. And we are very excited for you to partner with us as well as support us, and we support you. And finally, I'd like to say that on behalf of Secretary Kennedy and Deputy Secretary O'Neill, thank you, thank you, thank you. Your support is going to mean more than anything to this group, and thank you for the extra attendees that we have in the back of the room. You are going to be instrumental in the development of future policies. I'm going to now introduce Roger Klein, who is our Director of AHRQ. Roger.
Thank you, Cindy. Good morning. Thank you for the opportunity to join you here today. As Cindy stated, I'm Roger Klein, and I'm Director at the Agency for Healthcare Research and Quality, and I'm pleased to be here on behalf of AHRQ. I want to begin by welcoming the new members of the Advisory Council on Alzheimer's Research, Care, and Services. We're grateful for your willingness to serve and for the expertise and perspective you bring to this important work. This council plays a crucial role in shaping our nation's response to Alzheimer's disease and related dementias. Your recommendations inform both the Secretary of Health and Human Services and the Congress. I also want to thank returning council members, our federal partners across the HHS, and the staff who support the council's work. Your recommendations are central to the annual update of the National Plan to address Alzheimer's disease, and they help ensure federal efforts remain focused, evidence-based, and responsive to the needs of patients and families. Many, if not most of our families, are touched by Alzheimer's disease or related dementias, whether through parents, spouses, relatives, or friends. Alzheimer's doesn't merely impact those who are unfortunate enough to be affected with it. The disease changes the lives of patients' families and friends who are their caregivers. Under President Trump and Secretary Kennedy's leadership, HHS remains committed to advancing Alzheimer's research, care, and services. AHRQ is proud to assist that work by improving the quality of care delivery, enhancing the lives of families and caregivers, and contributing to the evidence base that informs how dementia patients are treated and how care is delivered. At AHRQ, our mission is to generate evidence that improves healthcare quality, safety, and accessibility and value, and to implement that evidence to improve patient outcomes. Alzheimer's disease affects every part of the care continuum, from primary care, specialty care, to long-term services and supports. It places significant demands on patients and families. Addressing those challenges requires rigorous research, thoughtful implementation, and sustained collaboration. AHRQ Senior Advisor Kevin Chaney will speak in detail about our efforts in dementia care. At a high level, this work focuses on improving care delivery and coordination, advancing quality management, supporting caregivers, and generating actionable evidence to improve real-world care. Our emphasis is on what works in practice. The Council's guidance helps ensure that these efforts remain aligned with national priorities and responsive to the needs of patients and families. We greatly value our partnerships with this Council and our colleagues across HHS and look forward to continuing to support your works in the months ahead. So thank you again for the opportunity to join you today and for your continued service. I wish you a productive and meaningful meeting. Thank you.
Good morning, everyone. Welcome. My name is Michelle Branham, and I have the pleasure, privilege, and honor of chairing this very exciting committee. As everyone in the room knows, I was very anxious to get started, so it's such a great blessing to be with you all today. Just to have a few opening remarks, and then I'm going to turn it over to Helen. Do you want to just have them quickly introduce themselves? Sure. Yes. So I was just wondering, because most of us are new, if we could go around the room and just briefly to each other and to the audience, just say a little bit about yourself, where you're from, and what brought you to the committee. Again, thank you so much for all the council members. I'm so excited to do the work with all of you. We have much to accomplish and a short runway to do it. So I'm looking forward to getting started and having some really meaningful and robust conversations here today. All of you, or most of you, know that I started with the Alzheimer's Association. I see them represented today, and found the greatest passion of my career there, serving those not only living with Alzheimer's, but their caregivers as well, and learning what true courage and inspiration meant to me. And it became really the hallmark of my career and my heart. So just a special thanks to Gina and Steve Waterhouse, who have been shoulder to shoulder with me, not only in DC, but in Tallahassee, showing me what true courage looks like. So thank you both for being here today. It's an honor to serve with you. So those of you that know me know that from the Alzheimer's Association, I went and became Secretary of Elder Affairs for the great state of Florida. I didn't know this, but I'm the oldest sitting secretary, oldest, not by years, I promise you. But by time spent, which means in a big state like Florida, we spend a lot of time. We have second highest prevalence in the country for Alzheimer's disease, over 590,000 Floridians currently living with the disease, about 1 million people providing unpaid care. So it greatly impacts our infrastructure, and Florida makes up about 18 states worth of seniors. So we really need to be the pioneer and lead the charge for not only research care, but services as well. So this committee means something to me personally. It means something to me professionally. And I'm just so proud and honored to be doing it with colleagues that I've worked alongside, some old, some new. So thank you all so much for being here. And I look forward to getting started. And I guess we can just start at the table here and just go around really quickly and introduce ourselves, if you don't mind.
This one works. Hello, everyone. I'm new to the council. My name is Valentina Mantu. I'm from the FDA. I'm a psychiatrist by training, but I studied regulatory in 2013, and I was talking to Dr. Bateman about this with Alzheimer's disease. And I think Alzheimer's disease has been my first love in terms of drug development. I've been trying really hard to advance drug development in this area, and I'm very happy to be here with you this morning.
Thank you.
My name is Melissa Miller. I'm the program manager of the Alzheimer's research program within the Department of Defense, specifically in the congressionally directed medical research programs. I come with a research background in neurodegeneration and neuroscience, looking in the towards drug development, and I'm really excited to be here on this council. Thanks.
Thank you.
Good morning. I'm Joan Weiss. I'm the acting director in the Division of Medicine and Dentistry at the Health Resources and Services Administration and the agency lead for geriatrics workforce development and enhancement. And I've been involved with workforce and development and enhancement in geriatrics for many years, probably going back to 2020. And you'll hear more about the work that we're doing later this afternoon. Thank you.
Thank you.
Hello, my name is Sam Giles. I'm a community neurologist and founder of a couple groups in this space. I'm out of Jacksonville, Florida. Our private practice setup is primarily to actually diagnose and treat with the most efficacious therapies, disease-modifying therapies for Alzheimer's disease in the community setting. We've been very busy in Florida, given our patient population. We are partnered with a national infusion company, and as a result, I have a bit of a unique perspective in seeing the clinical, administrative, and then also ambulatory infusion center hurdles, and then have been part of troubleshooting those. In addition, I'm founder of a solution called CerebraLink for looking at ways that we can help streamline and allow other neurologists that are in the community setting to deal with the administrative, clinical, and any other obstacles that may pop up.
Thank you, Dr. Giles. Good morning and happy Monday, everyone. I'm Christy Putnam. I am a 25-year-plus veteran in health and human services in Florida, Kentucky, and most recently in Arkansas. I'm originally from Florida, but now we live in Kentucky. My focus has been, so in all three agencies, I had supervision responsibility for aging and adult protective services and long-term services and supports. Really interested in how we can embrace AI and technology to help with some support, but also caregiver support and connection to community resources and making sure that we form those ecosystems around people that really help them through as family members and as patients. Thank you. Happy to be here.
Thank you so much. I'm Amy Bonnie Adams. I serve as the acting director for the National Institute of Neurological Disorders and Stroke at the National Institutes of Health. And we partner with our colleagues at the National Institute on Aging in advancing research on Alzheimer's disease and Alzheimer's disease-related dementias. I came to NIH over 20 years ago from a background in fundamental neuroscience and have been spending almost my entire professional career after leaving the bench working to take the results of research and thinking through how we can translate them into better care for all. So thank you so much. It's really a pleasure and a privilege to be here.
Good morning. Jonathan Weiss, great honor to be here. Michelle, we really look up to you, and thank you for all the work you've done prior to this and everything we're going to do together. I think we're going to do great things. My name's, again, Jonathan Weiss from the state of Florida. I'm a business guy, entrepreneur, and it's a great honor that you would seek to have my perspective here. Most recently, I served as the chairman of the Alzheimer's Disease Advisory Committee for the state of Florida. Part of what I do, or the technologies that I'm involved in, is able to, has an application for Alzheimer's disease, and so that's where I got into this space, and it is a mountain to climb for us, and with God's help, I hope that we were able to make a difference.
Good morning, everyone. Retired Major General Hammer Hartzell. It's just a call sign. It's a good one. A nice one, not a 37 years Marine, retired, served with Michelle in the great state of Florida as an agency head for Veterans Affairs. And when I retired, I wanted to serve those who served that I served with, and that's healthcare and behavioral health, mental health, a lot of different ways that we can do that. And when I realized that there's over 450,000 veterans living with Alzheimer's, and that the VA is predicting a 8.5% increase in veterans with Alzheimer's over the next 7 years, it's a battlefield that I want to fight in. And I have a passion for helping us stay as vibrant as possible as veterans for as long as we can. I have personal family members, my father, that dealt with this toward the end of his wonderful life. So that's why I was so honored to be asked to be on this commission. Yeah. Thank you.
I'm Randy Bateman, a neurologist from Washington University in St. Louis, and I began my work in Alzheimer's a little over 25 years ago, and I've been seeing patients in my clinic and doing research, and so much of my work has centered on the causes and how does Alzheimer's begin, how does it progress, and how does it take away the cognition and the thinking of our people. And over that time period, I'm going to present later today some of the advances that have been made over the past 20 years in Alzheimer's disease, including diagnostic tests, interventions, and then what the future might hold, the very near future over just the next few years, and what we might be able to do to help stop and prevent Alzheimer's.
I'm Richard Hodis, Director of the National Institute on Aging at the National Institutes of Health, where we support research across the broad spectrum of basic biology of Alzheimer's related dementias, the translation of that understanding into diagnostic and therapeutic interventions, as well as research on the care and services that are a part of dealing with those individuals with Alzheimer's and those who care for them as partners. It's been my privilege to be on this committee since its inception and to watch the enormous progress made and to express my gratitude to all those who've come to join us, and look forward to hearing from all of you and to presenting some of the summary of recent results from the National Institutes of Health in the next few minutes. Thank you.
Good morning, everyone. My name is Kate Newkirk, and my journey with Alzheimer's disease actually started when I was 12 years old, and my family became secondary caregivers for my grandfather, who was diagnosed with the disease. So I very passionate about care for patients and families, not only being a family member who cared for someone with Alzheimer's disease, but now practicing as a social worker in private care management, working with families and patients who are struggling under the weight of a diagnosis. So I'm very excited to be here and to learn from all of you and work with all of you as we address Alzheimer's disease together.
Good morning, everyone. I'm Maria Teresa O'Caffer. I'm with the HHS Office of the Assistant Secretary for Planning and Evaluation. Really excited to have everyone here. I see some new and familiar faces. I am the designated federal officer for the Advisory Council, and in terms of background, I'm a clinical gerontologist and epidemiologist.
And I think we have a few remarks from some folks on stage.
Yes, thank you very much. I would like to have the privilege of introducing Stephanie Herodopoulos, Dr. Stephanie Herodopoulos. She is the Chief of Staff for the U.S. Surgeon General's Office.
Well, good morning, everyone, and thank you for convening today. What an exciting group full of amazing experts. Now, some I know you, Jonathan Weiss, I've known you for a while, and there's some Florida people. I'm from Florida. I'm a family medicine physician, and I saw the whole lifespan of ages for over 2 decades there, did a lot of public health initiatives, and now I'm here. But I echo a lot of the passion and the personal experiences that you have all had. My father, diagnosed with cancer and Alzheimer's. I left my practice a couple years ago to be his primary caregiver and MD VIP, I say. You know, I reflect, and I just want to share a story with you. When we were sitting in Moffitt after his nephrectomy, and, you know, he had that acute delirium that happens, that sundowning. And he was an avid cruise ship goer before, of course, the diagnoses. And he said to me, "This is the worst cruise I've ever been in." He said, "The food is terrible, there's no activities." And although I had to find some humor in the moment, you know, I realized that, you know, it was the beginning of the end. And I had that precious time with him for 10 months before he passed. And so I have a similar passion. I can't wait to see what this work group comes up with a year from now. I know we have a crisis, and I know the numbers are increasing, but you have amazing minds that could help with diagnostics, therapeutics, and not only for the slowing, but reversal. I know you guys could do this. So I just wanted to thank you and welcome you to HHS, and I look forward to seeing your work throughout the year. Thank you.
Good morning, everyone. It's good to see you all. My name is Helen Lamont, and I work in the Office of the Assistant Secretary for Planning and Evaluation, or ASPE. Right now, I'm the acting Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy. I'm a gerontologist by training, and I look forward to working closely with everyone going forward.
Good morning, everybody. Thank you, Michelle. Sorry, my voice is kind of loud. For those that know me, thank you, Michelle, for the invitation to serve here. My name is Ricardo Hanna. I'm a neurosurgeon, born and raised in Brazil, working at the Baptist Jacksonville in Florida, dedicated for stroke and cerebrovascular care my whole career, to this opportunity of impacting dementia through surgery, first with NPH, now with Alzheimer. I think it's very exciting to see union of forces allowing us to do a science experiment. It is the REMIND study you guys are going to hear later this afternoon, where we're trying to increase the drainage of the lymphatics of the brain to augment the clearance of this protein deposit that turn into Alzheimer. So I heard from our National Society, I'm the first neurosurgeon to be on the Alzheimer Council, so I'm honored to be here and bring a potential different tool with all the drugs and developments that you guys made over the years. I think if we can bring a different perspective and hopefully enhance that for all these people. My grandmother, dear sister of my father, so this comes very close to my house. For those that know me, I'm very passionate and push hard for my patients. I think this should be about the patient, and there's no better place to make connections and push hard than from the capital of the United States of America. So I'm honored to serve our country and our Alzheimer population, representing the whole American Academy of Neurological Surgeons and the Congress of Neurological Surgeons.
Good morning. I'm Erin Long. I represent the Administration for Community Living, the Administration on Aging. I manage our Alzheimer's Disease Programs Initiative, which is basically a translation of science to community work and bringing long-term services and support and home and community-based services in a person-centered and strength-based way to our people living with dementia and their caregivers. And we have a very robust program, and I'm excited to learn with all of you on the committee.
Good morning, everyone. My name is John Corris. I'm the president and CEO of Tampa General and USF Health, which is a very large academic health system in Tampa, Florida, but we have centers and programs across the entire state. Michelle, thank you very much for inviting me to participate. It's a real honor. One of the programs that we have at TGH and at USF is a very large neurosciences program, one of the largest in the country. So from basic science to translational research to clinical care across the full spectrum of neurological disease. An aspect of what we do is called the Bird Alzheimer's Center on the campus of the University of South Florida that we're very proud of. So we do deep research in this space and deep clinical care. Like many of you, my father, who actually he's no longer with us, he was my best friend. He was just a very vibrant person, and I saw what Alzheimer's and dementia can do to a human being. And so there's a very personal component of all of this to me. And so when Michelle reached out, it's a real honor to serve our country, represent our state, and my health system, and it's great to be here. Thank you.
Hi, my name is Kevin Cheney. I'm a senior advisor at the Agency for Healthcare Research and Quality. There I help support our digital healthcare research division. I'm fortunate to have over 16 years in the federal government across a lot of different agencies, but I started my career at ARC after receiving my master's degree in gerontology from Miami University in Oxford, Ohio at the Scripps Gerontology Center. My background is actually helping with AAAs, area agencies on aging, long-term care services, supports. I worked at the Knolls of Oxford in the dementia ward. And so I have a lot of familiarity working with individuals and their families. And so now to flash forward, all of these years where I've been really steeped in the digital healthcare, world, is how can we leverage digital healthcare technologies to best support not only those with Alzheimer's disease, but especially friends, families, caregivers, as well as the health systems and the clinicians that are trying to take care of these individuals and support their families. And I'm very excited and happy to be here. Thank you.
Hi, we're Steve and Gina Waterhouse. Thank you for your kind words, Michelle. We've been in this battle since 2016 when Gina was first diagnosed and is still here and doing well. Sorry. She wants to torture me. But obviously, our goal is to help make the path for those like us easier and more effective, and appreciate all of the people here trying to make that same goal a reality. Thank you.
Good morning, everyone. I'm Michael Mayo, and I served as president and CEO for Baptist Health in North Florida. It's a 7-hospital system across Northeast Florida, the largest employer, 16,000 team members, home of the Lyerly Neuro Institute, where Dr. Hanel and I have partnered and worked together for many years. I most recently retired from that role after 15 years and was welcoming the opportunity when Michelle called me to serve on this committee to continue to contribute to the betterment and quality of the care of the people in the communities that we serve. And so I look forward to being here with all of you and with my colleagues.
Good morning, all. My name is Sherry Lang. I'm representing the Centers for Medicare and Medicaid Services, and have had the honor of representing CMS as part of this council since its inception, along with Dr. Hodes. I am in support of the agency's work to improve care, quality, access. You'll hear a little bit more about the agency's work in serving people living with dementia, including those with Alzheimer's, and also people at risk of developing dementia. I am a geriatric medicine physician and also a gerontologist in the direct services track, and have had the honor of federal service since 2000, initially helping stand up the normative aging program known as the BLSA, working for Dr. Hodes, and subsequently working as a medical officer for Centers for Medicare and Medicaid Services. It is indeed an honor, and I welcome the new members and advance thanks for the hard work ahead that we will be doing together.
Good morning. My name is Jolie Crowder. I'm right here representing the Indian Health Service. I'm a nurse. I can officially say this year it's 30 years in nursing. So excited to bring the nursing experience to the group, as well as representing the values of American Indian and Alaska Native communities. I'm the National Elder Care Consultant and lead our Alzheimer's work, as well as our elder health care team at Indian Health Service. So really excited to be here. I think we're doing some really great work. I've only been a Fed for 3 years, so it's been quite the immersive experience. And my background actually was nonprofit work, associations, worked with an International Indigenous Association and tribal communities for 14 years. So appreciate your time, and welcome to all the new council members.
Good morning. I'm Bob Weathers. I'm the head of disability policy at the Social Security Administration, and we're excited to be new members of the Advisory Council. My research is focused on the economic of aging and disability, with a particular emphasis on Social Security policy. Within our office, we lead the policy efforts within the agency on the disability insurance program and the disability component of supplemental security income. And we also lead disability research within the agency. Two areas that we're looking forward to working with the council on are improving our disability insurance program and SSI disability programs as it relates to Alzheimer's disease. And the other area is the representative payee program that we need to administer for all of our programs, including retirement benefits. And that can be a particular issue for people with Alzheimer's disease. Thank you.
Hello, I'm Michael Goldstein. I work with Bob at Social Security Administration. I am the Director of Medical within Disability Policy. I'm excited to be here. It's an honor. I've got a bit of experience working across agencies. A number of the sub-agencies within HHS regularly work with them, and others throughout the federal government, and thoroughly enjoy working with the different advocacy communities across the spectrum as far as those afflicted with various medical impairments. Honored to be here. Thank you.
Thank you, everyone. And someone special just stepped into the room that I was hoping would introduce herself.
Thank you, Michelle. I appreciate being here. I'm sorry I'm late. I'm running from one meeting to the next. My name is Mary Lazaire, and I am the individual who is serving as the administrator with the delegable duties of the Assistant Secretary on Aging. So that's a mouthful. Anyway, this is my second opportunity to be here at HHS. I was here during the first Trump administration, and like a bad penny, here I am again. But it is an absolute privilege and a pleasure to be with all of you today. And Michelle, with your convening of this group, I know things are going to be outstanding. I'm at the Administration for Community Living here at HHS. The Administration for Community Living, albeit ACL, focuses on two populations, older adults and people with disabilities across their lifespan, as well as the caregivers for older adults and those who support people with disabilities. ACL is focused on community living. So while we do not do direct health services, we're certainly very focused on community living support services, particularly supporting people who need respite, caregivers who need respite, individuals who need caregiver services, advocacy, support. So we are very tuned into the work of this committee and appreciate all that you do. Hopefully you'll hear later from Aaron Long a bit more about the specific programs that ACL does provide. But with the growing, I'm going to say maybe the wrong healthcare word, but epidemic of this issue among older adults and those not so older, which is certainly becoming more and more of an issue facing all of us, that becomes more of an issue for all of us in terms of community living. So that's why it's important for the support services to be available as well, and it's our privilege to be here with all of you, and thank you for being here. Thank you, Michelle.
Thank you. And if you aren't feeling reassured, all of you members and audience, that we have assembled such an amazing group from just different spaces in the disease, whether it be caregiving, research, health systems. But our job here, I feel like our mission, what we are commissioned to do here, is not only to create runway, but to fly the plane. So we've got some work to be doing here that will be, I think, just incredible as we convene not just the research that will advance while we have caregivers and people living with the disease, but also how we wrap services around our families in America living with the disease now while we keep working on research. So I'm excited to get started. Thank you all so much for being here. With that, I'm going to pass it to Helen, who has had to deal with me the past couple of months to get started and has just been a terrific partner. So thank you so much to ASPE for all the assistance and all the support.
Thank you, Michelle. I just want to acknowledge there are a few federal members who are online. For the sake of time and technology, we will have them introduce themselves when they talk about their federal agencies today. But they're also very important, so I don't want them to be forgotten. So again, good morning, everybody. My job today is to give you an overview of what you're walking into. What is this NAPA, as we call it, the National Alzheimer's Project Act? What does it mean? What is the infrastructure? And the goal of today is to sort of level set so that we can take off. So first I want to do a little bit of history of NAPA. This is a tricky one. It was passed in late 2010 and it was signed into law in early 2011. It's a short, I think it's 3-page piece of legislation, and it's relatively straightforward. These are the requirements for what the Secretary of HHS needs to do, and it includes 2 main pieces that are what I'm going to talk to you about today: create and maintain an integrated national plan to overcome Alzheimer's, and to create an advisory council, this group today, to review and comment on the national plan and its implementation. It's quite simple, but it's had a big impact. And I also want to mention, especially as we move into the next decade, that Alzheimer's disease in the legislation specifically calls out related dementias. So when we use the term Alzheimer's disease, with the exception of our scientific discovery and research, we are often talking about Alzheimer's disease and related dementias holistically, and we don't forget about the related dementias. So this is a not to scale timeline of NAPA, but you'll see it was enacted in January of 2011. We took over in April. We had our first meeting in September, and then our national plan came out, the very first one came out the following May. So it was quite a quick turnover the first year. And then following that, we've updated the national plan annually. It's been consistent except for in 2021 when we added a goal focused on risk reduction, goal 6. And then we were so pleased, well, now 2 years ago when NAPA was reauthorized on October 1st. Originally, it was set to sunset at the end of 2025, but recognizing the importance of this work, adding some members, and codifying the focus on risk reduction, we really appreciated Congress's support for this work into the next decade. So first I want to talk about, out of order from the legislation, the Advisory Council, or this group. This group is governed by the Federal Advisory Committee Act, or FACA. So if you ever hear it informally, we sometimes call this the NAPA FACA very affectionately, and that's our shorthand. All it means is that our deliberations are in the public domain and that we have meetings where we vote on recommendations. This group meets quarterly. You all are charged with making annual recommendations, both to the Secretary and to Congress. That's a really important and unique aspect of this advisory committee as opposed to other FACAs, because the breadth and depth of the issues that we're facing are so large. I think that the authors recognize that it's outside of HHS's purview to tackle everything. And so many times our advisory council will come up with recommendations that require statutory changes, and we have the authority to make those recommendations to Congress, and they have acted on a number of those, which is really exciting. And the way that we organize our work historically has been, I think, going forward in 4 subcommittees that roughly align with research, care, and services. So a research subcommittee, a clinical care subcommittee, long-term services and supports, and then risk reduction, which was again added. That was added in 2020. So sorry for the wonky graphics. This is a rough timeline of the work that we do, just so you can get an idea. We might have to adjust it, of course, because we're meeting this year in February. But our goal is for the recommendations to inform the national plan. And the national plan, if you go backwards, I don't know where I could point, is released in the fall. So what we try to do is have this group make recommendations at the July meeting. Maybe we'll do it in October this year. And then historically, we've had meetings focused on various different topics to inform the development of recommendations. So this is a January meeting. Historically, we might have done this meeting on clinical care, with a focus on clinical care, and April 1 on risk reduction and research, and then in July we would have the recommendations, and then October would focus on long-term services and supports. A lot of the meat of the work happens in those subcommittees, which I'll get into in a few minutes, and so those subcommittees generally are working from that January to July timeline, developing the recommendations for presentation and adoption in the July meeting. So we'll meet quarterly. Our main deliverables are the recommendations, and then the HHS's deliverable is the national plan. Our advisory council has now more than 30 members, which is amazing. We have our non-federal members, many of whom we welcome today, with a variety of perspectives codified in law, what we have to have here on our council, and then more than 15 federal members representing almost every part of HHS, the Department of War, NSF, VA, and then this year we are pleased to add DOJ, FEMA, and SSA. Again, NAPA is a little different than every other advisory committee or many other advisory committees. Most advisory committees don't have full membership for federal members. They're often ad hoc or ex officio. So in the beginning, this was a little bit, we had to figure out how to make this work. But I think we've really developed collegial relationships where what the federal members do, the non-federal members lead the content of what we're focusing on. They tell us what's important, and then your federal colleagues will help you figure out technically how you achieve that goal. So as a result, we have very rich, specific recommendations. We don't just say improve life for caregivers. We will say a recommendation from this group might say, through the National Family Caregiver Support Program, Congress should increase the focus on X population. And so we are very explicit on who we're focusing on. And I think that has helped us to become more effective in the work that we do. And it works the other way. We are also hearing all of this within HHS. We're hearing the specific focus areas that the non-federal advisory council members are interested in. You all will make recommendations to the secretary, but also know that there's a little more diffusion process where by us feds sitting at the table and hearing, for example, that there's a population that we need to focus on, like people living alone with dementia. Your federal colleagues will take that back to the work that they do and add it to the work that they're doing. So it's both a very formal process, but then the informal part of it has been extremely important as well. I apologize. This slide is really hard to see, so you can read it afterwards. So our 3 subcommittees, just quickly, research focuses on not just biomedical research, but all research. It has focused in the past on funding, clinical trial enrollment, and research infrastructure. As Dr. Hodes will discuss, there are a number of summits. Actually, every year there is a summit to get down to more specific research focus that NIH should have. So this research subcommittee is sort of a 10,000-foot view on the research infrastructure that we need to address Alzheimer's disease. The clinical care subcommittee focuses on everything from detection and diagnosis to the workforce, models of care, treatments, all the way through end of life. Long-term services and support subcommittee focuses on institutional and home and community-based services, efforts to support family caregivers, and issues like safety and autonomy. And then finally, our risk reduction group, which was added with the new research that showed that there were steps that people could take and that we could take as a society at large to improve the health of folks, but also to reduce their risk of developing dementia, looks at people in the preclinical stage, building the research evidence regarding risk reduction, building the infrastructure to act on that research evidence, and then making sure that we're spreading the word about things that we can be doing to reduce the risk of developing dementia. Most of the substantive work and discussion happens in the subcommittees, not in these big meetings. It would be far too much. Generally, those subcommittees meet monthly for an hour to an hour and a half. They're organized by the subcommittee chair, so stay tuned for your ask to be a subcommittee chair. They may also work on planning a panel for one of our quarterly meetings. And then most importantly, they craft the recommendations for presentation at the July meeting. And as I mentioned, our federal staff provide technical assistance on those subcommittee meetings. And then internally, we have a lot of federal coordination happening. We meet regularly to talk about the work that we're doing, what's coming up with NAPA, and better ways to coordinate. I would say, again, this is both formally and informally. The relationships that have been developed between the agencies as part of NAPA don't have to go through NAPA. So if Joan at HRSA has something that she wants to be doing with ACL, she will reach out directly to Erin, and it's been a great way to extend the reach of the work that we do. We coordinate and collaborate on many issues, and then obviously are leveraging resources between the federal agencies to achieve more. As Sherry mentioned, she's been here since the beginning. Dr. Hodes has been here since the beginning, and the others, Joan has, the others that have not been here maybe since 2011 have been here for a very long time, and we've really appreciated the consistency in federal staff and federal leadership focus on NAPA, and so that's been a way to elevate the issues that this advisory council makes. I'd say across the board, you'll notice that, well, with many issues, of course, but with dementia, that there's sort of a whole of government recognition of the importance of dementia, the impact that it has on all of our programs, and in an effort to address those challenges that people are facing. And it's been used as a model. Recently, the national, I forget the exact name, the Parkinson's Act is actually almost exactly the same as the National Alzheimer's Project Act. So it's really flattering, and I think a testament to what can be done through this infrastructure. And then finally, you might have noticed that you're seated in and out, fed, non-fed, and that's intentional because our goal is to develop these collegial and personal friendship relationships between our feds and our non-feds to make this work richer. I will talk a little bit more later about our national plan to address Alzheimer's disease, but really quick, it has 5 goals. I don't want to get too far into it. They roughly follow research, clinical care, long-term services and supports. We recognize public awareness and engagement, and then infrastructure to track our progress. And then the last goal, not in the order that it was added, is focused on risk reduction. And again, we'll talk about that this afternoon. It is updated annually. The current draft for 2025 was held up by the prolonged shutdown, so that's currently in our clearance process, so you'll see the 2025 update out soon. Underneath each of our goals, we have strategies, and then we have specific steps that the federal government is taking to achieve those goals. Historically, the national plan has summarized all the completed, current, and planned work that the federal government had underway, and so the 2024 update was north of 170 pages. It was really a comprehensive book of everything the federal government was doing. And then the actions that are in that national plan come from the recommendations. They come from public comments that we'll get at the end of the day, issues in the field that your federal colleagues are hearing about and working to address, and then topics raised by federal partners and those cross-agency collaborations. So where are we today? What does that put us today? And how do you do something when you're joining an effort that's been underway for nearly 15 years? So here we have an almost entirely new slate of non-federal members, which gives us new energy and fresh perspectives. We don't want you to think like, gosh, I'm coming into this, what can I possibly do? But really we have 15 years of success and partnerships to build on. So we're sort of primed to achieve more, to do much more in the coming decade. We have new energy from the Trump administration and opportunities with the Make America Healthy Again initiative, which, as you know, aligns very well with dementia risk reduction. And that NAPA reauthorization underscored congressional commitment, and Congress has really been supportive of this work across all of the agencies through research, through funding, and through recognition of NAPA. So we see an opportunity to build off of all of these things that are happening at once and to reimagine our national plan to serve us for the next decade. And we'll be talking this afternoon about how we go about doing that and the role that this group will play in that work. So today's agenda is to learn about the federal agencies' roles and progress. You will hear about agencies you've never heard of before, and there will be a lot of acronyms, so apologies in advance. We'll do our best on acronyms. But we thought it was important for you all to understand the landscape of the work that is happening and what has been achieved. We will introduce our new federal partner agencies who we've been working with in the past, but now are formally parts of the advisory committee. We'll learn about some innovations in the field, and Dr. Bateman will tell us about how those innovations can start to inform recommendations. We'll discuss an approach for this national plan in 2026, which is going to be our roadmap for the next decade. And finally, a really important part of our meeting is to hear public comments at the end. So thank you all for being here today. I think that's it.
Thank you so much, Helen. Oh my goodness, we've got a lot of work ahead of us, don't we? But 15 years of outstanding infrastructure in place. But I think Helen's right. We have lightning in a bottle right now, a lot of opportunity from the administration, a lot of great minds here at the table, and just a research pipeline that is so robust and energetic. So I think the time is now. I'm going to pass it to Maria, who's going to introduce our new federal partners, correct? Yes, thank you, Maria.
Thank you, Michelle. So now we'd like to introduce 3 new agencies that have joined the council. So we're going to start things off with the Department of Justice. So I see Andy Mayo's on the line. Turn it over to you.
And thank you for allowing me to join. I'm sorry I can't be there in person. My name is Andy Mayo. I'm the Department of Justice's National Elder Justice Coordinator. And in that capacity, I help to coordinate the department's law enforcement and prosecutorial efforts to combat elder fraud and different forms of elder abuse. In that capacity, I also help to coordinate and support the efforts of state and local law enforcement and prosecutors in their work to combat elder abuse, neglect, financial exploitation, and fraud. Obviously, in all of our works at the federal, state, and local level in combating elder abuse, elder fraud, elder financial exploitation, we interface and intersect with older adults, living with Alzheimer's disease and other related dementias. And so something that we have been working on for the past several years is how to improve our agents, our investigators, and our prosecutors' interactions with those older adults. And so, for example, we developed a forensic interview training that we have done in almost all 50 states, teaching law enforcement officers and prosecutors how to conduct more effective forensic interviews with older adults, including those living with Alzheimer's disease and other related dementias. On Wednesday of this week, we're going to do another training for the elder justice coordinators. These are prosecutors in every one of the U.S. attorney's offices with a responsibility for prosecuting elder fraud. And we're doing a training for them on the aging brain, what we know today, what we don't know today, and some of the best practices for interfacing with and interviewing those older adults. So again, I applaud the work that you're doing. We're thrilled to be a part of this and thrilled to learn more about your efforts. So thank you very much.
Thank you so much, Andy. And now we'll turn it over to FEMA with Michael.
Good morning, everyone. My name is Michael Vukovic. I'm the Senior Director of the Integration and Coordination Division with the Federal Emergency Management Agency, and it's a pleasure to be here today and to join the Council. FEMA's mission is to help people before, during, and after disasters, and that mission includes individuals with disabilities, including Alzheimer's disease and their caregivers. FEMA's Integration and Coordination Division ensures compliance with federal civil rights laws and disability statutes across FEMA, as well as for recipients of FEMA's financial assistance. It's a privilege to join this distinguished council and to represent FEMA as we work to address the critical challenges posed by Alzheimer's. I'm grateful for the opportunity to contribute and look forward to collaborating with all of you. FEMA is committed to supporting and integrating emergency management expertise into the national strategy for Alzheimer's care and support. FEMA currently has over 80 civil rights and disability integration members who deploy on-site to disasters to ensure access for the public, including people with Alzheimer's and their caregivers. These professionals are on the ground during disasters to advise on civil rights and disability integration laws, compliance strategies, and best practices throughout all phases of disaster response, including preparation, mitigation, and recovery. Those civil rights cadre members work closely with federal, state, tribal, and local partners, such as Alzheimer's organizations, to address the community needs and provide specialized training to support people with disabilities, including people with Alzheimer's. In the past, we've partnered with the Centers for Disease Control and Prevention, fire departments across the country, and the Alzheimer's Association. FEMA provides disaster preparedness training and information as well to caregivers and first responders, and equipping them to care for individuals with Alzheimer's during emergencies. Our resources include guidance on developing emergency plans and preparedness kits, as well as practical guides to make sure caregivers and responders have what they need to meet the unique needs of this population. In partnership with the Centers for Disease Control and Prevention, our U.S. Fire Administration provides the Fire Safe Seniors program, which helps organizations who serve older adults implement fire safety interventions. It also, that program includes a toolkit and guide with essential information for providing and implementing fire safety initiatives tailored to high-risk seniors such as those with Alzheimer's. We recognize at FEMA that collaboration is essential to our success, and as such, we provide technical assistance to state and local partners and coordinate with agencies already, including the Administration for Community Living, the Centers for Independent Living, state offices of aging, and memory care facilities to connect survivors with various vital resources. In addition, our FEMA voluntary agency liaisons help individuals with unmet needs access appropriate services. And by working closely with partners, FEMA gathers critical data, evaluates disaster areas by disability type, and advises on resource allocation. This ensures that individuals with Alzheimer's receive responsive support. Our partnerships also strengthen our ability to provide critical messaging and services, including FEMA-funded community service programs like disaster case management, crisis counseling, and disaster legal services. Our teams manage communication accessibility kits and provide staff training on disability etiquette to foster positive interactions with survivors. In addition, we integrate enhanced applicant services that supports individuals with disabilities and their caregivers in applying for disaster assistance. Disability coordinators throughout FEMA's regional offices also ensure the needs of individuals with disabilities are integrated into emergency planning and disaster relief. These coordinators promote best practices in evacuation, develop training materials, and ensure access to pre- and post-disaster information, while also working on transportation options and post-evacuation guidance. In closing, I want to reaffirm our commitment to this advisory council and the efforts to address Alzheimer's disease and related dementias. Our agency is dedicated to making sure that individuals with disabilities, including those with Alzheimer's, are integrated into every aspect of disaster preparedness, response, and recovery. And as we move forward, FEMA will continue to collaborate to strengthen our emergency management principles, ensure access, and provide support to all disaster survivors. I'm honored to serve alongside each of you, and I look forward to contributing to the Council's critical work. Thank you for your time and commitment to improving those affected by Alzheimer's. Thanks.
Thank you so much, Michael. And now we'll turn it over to Dr. Robert Weathers with the Social Security Administration.
Good morning. I'm Bob Weathers, Head of Disability Policy at the Social Security Administration. We're happy to be new members of the Council. Social Security administers two programs, the Old Age Survivors and Disability Insurance Program, or OASDI, and the Supplemental Security Income Program, or SSI. People with Alzheimer's disease might be eligible for either our disability insurance program or disability under SSI. And Michael will talk a little bit about the disability program and how it serves people with Alzheimer's disease this morning. We also administer the Representative Payee Program for people with Alzheimer's who are unable to manage their own benefit amount. And that could be for retirement benefits, disability benefits, survivors benefits, or SSI aging benefits. So that's another area that we would like to focus on with the Advisory Council in our new role here. So with that, I'm going to pass it over to Michael Goldstein to talk a little bit about the disability insurance program.
Yeah, that's good, actually. Thank you. Thank you, Bob. And forgive me in advance. If you have any questions, I'd do a lot better with this with a 4-hour presentation than in 5 minutes. There's a lot of details and nuance that I got into 5 slides. So if you want to approach me, at any time today, please feel free to do so. We did think that given our new membership here, it was important to give a little bit of context about how we run our program and how we specifically determine disability and talk about that in the context of Alzheimer's disease. So real quick, you can see here, this is at the top is actually based on the statutory definition from the Social Security Act and how we determine disability. We're looking, are you working and earning certain income? You cannot be disabled if you are. Do you have an impairment that is severe and meets our durational requirements, which is at least 12 months or likely to result in death? That's actually a fairly easy threshold to cross. Rare is that someone going to be denied at that step. We'll focus a bit today. I'll talk about the medical listings that are applicable to Alzheimer's disease. It's a screen and step there. If you do not meet one of those listings, at that point we see if you are able to do your past relevant work. Again, a lot of nuances in these definitions here in these terms of art. And if you're not able to do that, we then look, are you able to adjust to other work in the national economy? For Alzheimer's disease, primarily, we're looking at listing 12.02 for neurocognitive disorders. So a lot of these listings are broader. They cross 14 body systems for adults, and there's several hundred, right, crossing every impairment you can imagine. And then there's obviously thousands upon thousands of other impairments that don't have a listing. This Alzheimer's typically fits under 12.02. So we're really focused on the declines in attention and executive function, learning and memory, language, social cognition, perceptual motor skills, and then also looking at the criteria marked limitation, and a couple is often what we see, but sometimes extreme limitations in one of understanding, remembering or applying information, interacting with others, concentrating, persisting, maintaining pace. I think a lot of elements of Alzheimer's disease, as you all know. There's also other factors and elements under 12.02 that look at really extensive levels of treatment that we'll see at times. Like I said, we will never deny somebody for not meeting these specific medical criteria. We then go on to the vocational analysis, and at this point, we look at your residual functional capacity. Some of you might hear about claims that go before ALJs, administrative law judges with their agency. A lot of these are decided at this level, right? Whether they're allowed or disallowed. And it's looking at the most you can do. Given your impairment, what is the most you can do? And it's also factoring in your age, education, and work experience. So we take that, and then we look at your past relevant work. Can you do your past relevant work? And if you cannot, can you do other work, given those factors that I mentioned? The answer to both those questions is no. The individual is found disabled, and if it's yes, then it's not disabled. We do have one of the things I should mention is in the context of Alzheimer's and disability, we're inherently sort of talking about a younger population, right? Because between age 65 and 67, you're going to transition into the retirement program based on several factors, whether that's Title II or Title 16. So there's this inherent kind of element of being young, right? So we have a wonderful program that was started by Commissioner Astrew. I believe it was in 07 or 08. He was there through numerous administrations. He started a compassionate allowance program. And we've got about 300 conditions on that, and that is for some of the most severe impairments that we see, to ensure that these people are fast-tracked as far as their disability analysis and determination process. Inherently, these are going to have pretty high allowance rates. It's not a guarantee that they're going to be allowed, but it's close to that. And you can see there's several types of Alzheimer's disease. I think the most prevalent we're going to see is early onset or young onset Alzheimer's throughout our program and their caseloads. So we do quite a bit of collaboration and outreach, and that's part of what my team at SSA does, is they're constantly doing research and staying up on Alzheimer's and all other impairments. But we also have some built-in relationships. Like I said, I have several strong relationships with folks here at HHS, but we're constantly engaging with the national academies, great relationships there, and have a couple of different forums that we're exploring. Currently, we're exploring different elements of not just the medical side of Alzheimer's and treatment and what we're seeing, particularly with the young onset, but also, as Bob was saying, with what we're seeing in the realm that affects our rep payee policy, because obviously folks afflicted with Alzheimer's, whether it's disability or retirement, are going to have different needs and different abilities related to their benefits. So we're doing that, and as always, it's very fulfilling to work directly with the community, the Alzheimer's community, and engage with them. And currently, I was just talking a week or two ago with folks from the advocacy community and getting their input, and excited to continue that. And as it says up here, we're looking at some of the young onset, early onset, updating some of that policy. So now, Laura, if I don't do anything in the next few months, I've put it out here in the public sphere that it's going to happen. You can really hold my feet to the fire. But again, it's an honor to be here. I love kind of working with the community, and I know you all are a conduit to this community, and just look forward to serving. So thank you.
Thank you so much, and welcome again to our new federal partners. So we're going to pivot a little bit and turn it over to our continuing federal members, who will be presenting overviews of their respective agencies and highlighting progress made since NAPA's inception. So I'll turn it over to Drs. Hodis and Dr. Bainey Adams for NIH's presentations. Thank you.
Thank you very much for the opportunity to address the group members, old and new. We at NIH are constantly engaged in efforts to pursue the impacts of dementia. This first slide just is a quick summary of the impact of it. These numbers themselves are a result of ongoing research. In 2025, estimated there's some 7 million people living with dementia. Expected to increase to nearly 14 million by 2060, largely as a result of the aging of the American population. One recent estimate was that the cost of dementia will be some $781 billion this year. This impact both in terms of direct medical care and some of the indirect consequences, well beyond medical costs, therefore, including the hours of unpaid family caregiving, earning losses, and declines in quality of life. For an overview of NIH, NIH is the primary U.S. government agency responsible for biomedical research, comprised of 27 institutes and centers. Two of these, the National Institute on Aging and the National Institute of Neurological Diseases and Stroke, represented here, are those which collaborate very closely carrying out research in Alzheimer's-related dementias, though many of the other institutes also play a very active role. In terms of NIH engagement with NAPA, we are participating on the Advisory Council, and that's why we are here. Participate on the subcommittees that you heard outlined as well by Helen, and are advancing progress towards goals targeting the understanding of Alzheimer's and translation of that understanding into interventions to prevent, treat, cure, and to deal with the challenges of those currently living with dementia. In terms of efforts to advance the goals, there are research efforts looking at the basic mechanisms of the biology underlying Alzheimer's. The purpose of this is to improve the ability to diagnose Alzheimer's-related dementias and to monitor the progression of disease, either the natural history or as we move towards intervention, to monitor the impact of successful interventions, to delaying the onset and progression of disease, reducing the burden and preventing disease, and improving medical care. In terms of tracking progress in this, there is an ADRD, Alzheimer's-related dementia research implementation milestone set, and a public database that I encourage any or all of you to take a look at. It's an effort to identify the milestones involved in achieving the goals of the Alzheimer's National Plan and documenting annually the progress towards those plans so we can strategize optimally in pursuit of what our common goals are. We track these through implementation of milestones in these general categories you can see listed here: epidemiology, disease mechanisms, diagnosis and disease monitoring, translation, dementia care, research resources, and Alzheimer's-related dementias, in addition to Alzheimer's itself as a primary focus. They're, as Helen alluded to, focused on input from a number of sources, but among them are the annual summits that are held, one each year, rotating through the three summits shown here. So in 2025 was the Alzheimer's Disease-Related Dementia Research Summit. In 2026, coming up next month, the Research Summit on Care, Services, and Support for Persons Living with Dementia, and then in 2027, the Alzheimer's Disease Research Summit. These are international meetings with hundreds of participant input from leaders in the field that lead to evaluation of our milestones, progress, establishment of new milestones, and trying to optimize the progression of our research and investments, along with the other many important sources of input that we have. The professional judgment budget for Alzheimer's-related dementias is required by a law. Congressional action since 2016 requires that each year the director of NIH communicate directly to Congress, that's why it's a bypass budget, doesn't go through a usual budgetary process, an estimate of the funds needed above current levels to optimally pursue the goals and targets of the annual plan. This is then used as the metric by which we can measure progress and continually revise the targets and goals thereof. Quite a remarkable slide shown here, which illustrates the bipartisan, bicameral, congressional support there has been for Alzheimer's disease over the years. is this slide, which illustrates over the past years of the existence of this meeting from 2015 through 2024, a total from about $1 billion to now over $3 billion, really a remarkable level of funding. The increase is some 6 or 7-fold in Alzheimer's-related dementias and Alzheimer's itself, reflecting the way in which the public recognizes the importance and the effectiveness that we've had in addressing the challenge of Alzheimer's disease and related dementias. I'd like to turn now to our closest partner in crime, the National Institute of NINDS, and the current acting director who introduced herself just shortly ago, Amy.
Thank you so much. The National Institute of Neurological Disorders and Stroke has the lead for the research supporting Alzheimer's disease-related dementias. So the lower line that you see in the graph here reflects the investment in the related dementias research, which includes some funds that are appropriated directly to NINDS. What you can see here is that investment in research for these related dementias has kept pace with the overall investment in Alzheimer's disease and Alzheimer's disease-related dementias, perhaps even slightly outpacing it, almost an 8-fold increase in investment in this area. Would you mind, Dr. Hodes, advancing the slides? Thank you. From the first version of the Act and the initial national plan, the importance of research into these related dementias was recognized, and 4 of these related dementias were named in the Act. And so as a result, we call them the named related dementias, and this includes Lewy body dementias, frontotemporal dementias, vascular contributions to cognitive impairment and dementia, and mixed etiology dementias, or dementias that have a variety of causes. But science continues to evolve, and we keep pace. And what we have come to understand is that there are other dementias and other emerging pathologies that fit within this ADRD framework. And so now our research portfolio also includes projects in some of these other areas. For example, in our growing understanding of the cognitive impairment that can emerge from traumatic brain injury, and also the dementia that can come from repeated head trauma or chronic traumatic encephalopathy. Next slide, please. Indeed, the mixed etiology for these related dementias is increasingly a central area of focus. As has been mentioned already, the global prevalence of dementia is rapidly increasing, and we have a growing understanding, but still imperfect, of the wide-ranging and complex genetic and environmental risk factors that are contributing to that increase. As we continue to understand it better, it becomes also increasingly complex. And now we have a greater understanding of the overlapping clinical presentations of different dementia diagnoses, often in the same patient. So a single patient can have multiple systems disrupted. This includes different types of abnormal protein folding, not just amyloid, which you've heard about many times, but also tau, alpha-synuclein, TDP-43, and others. Also, inflammatory systems can be disrupted, metabolic systems can be disrupted. The vascular system, which supplies blood to the brain, can be diminished and otherwise affected. And of course, we can have cellular aging and death. And all of these need to be teased apart as we gain a greater understanding of how we can advance treatment to these patients. Next slide, please. And in fact, the multiple pathologies are critically important for a variety of reasons. So in this slide, you're looking at a group of individuals that had a clinical diagnosis of probable Alzheimer's dementia. But upon pathological examination, what became clear is that actually only a subset of them had pure Alzheimer's disease, which would be characterized by amyloid plaques or tau tangles. The vast majority actually had a combination of Alzheimer's disease and other forms of pathology, which includes vascular and other neurodegenerative markers and signs of protein aggregation. So it's important to understand the complexity here for a variety of reasons. one of the focuses of our effort is thinking through how we can develop biomarkers so that we can more clearly understand what is going on in each patient. What types of pathology or other disruptions are they contending with? Not only so that we can track the outcomes for those individual patients, but also as we design clinical trials. It's critically important that we can track the outcomes for these patients, but also so that we can ensure that we have enough patients with these different combinations of pathologies that we can understand how the treatment under study is affecting that particular group. So this greater understanding, I think, will pay off as we move forward in being able to advance therapy development more effectively. Next slide. As Dr. Hodis mentioned, we use these summits to help shape our priorities moving forward. The plan really is a living document. So it's not just the incredible input of the amazing experts assembled here today, but through this annual process, we were able to bring in experts from across academic science, clinical communities, government experts, but also experts from industry and nonprofits. And critically important, we bring in people with lived experience, the patients, the caregivers, their families. It's a very interactive series of meetings where together we come to a greater understanding of what really are the priorities. In the related dementia space, for example, this last summit, which was held in 2025, our fifth of these summits, really called for us to focus on implementation research, thinking through how to advance our understanding into more direct care. How we can understand the impact of the exposome or an individual's cumulative environmental exposures on their risk, individual risk and outcomes in Alzheimer's, and also to greater understand both the named and some of the other emerging dementias and how they interact with each other. So with that, I'll hand it back over to Dr. Hodis.
Thank you, Amy. Just wanted to emphasize the way in which research over these past years has informed us of the complexity of pathways and etiologies that Amy summarized, which in turn is translated into the diversity of interventions that are being supported. This first slide shows the non-pharmacologic interventions that are currently under study, ranging from exercise to cognitive training to diet to sleep. A very important part of treatment and prevention, secondary prevention and primary prevention. And these are randomized clinical trials that over these next years are going to give us increasing information about which of these are important contributors and which we can effectively intervene upon to delay or decrease the risk of Alzheimer's disease and related dementias. Similarly, in the area of pharmacologic interventions, as we've learned more about the basic pathologies in the brain, we've translated that information from genetics, genomics, proteomics you've heard so much about, with methodologies that increasingly are involving artificial intelligence as well, to take huge amounts of data and from them to identify potential targets for drugs. These drugs can be small molecules, immunotherapies, gene therapies, vaccines, and they address the very diverse number of targets you see here. Those 50 trials are the early stage, phase 1 and 2. How they do, and those interventions determines which move on to phase 3, the definitive trials. And although amyloid remains important, you can see that for many years now it's actually been a minority player, an important one, but among many of the diverse targets that we're addressing. So as we learn more, the number of targets will increase, and our ability to individualize them, as I'll point out toward the end of these few minutes of conversation, to personalize the approaches to individuals. The NIH supports a translational research program that importantly allows individuals with ideas from public-private sector to propose their ideas, to have support from the earliest stages of preclinical intervention through preclinical trials and into the clinics. In addition to the trials that are looking at treatment and prevention of disease itself, we've talked about the critical importance of care and caregiving. And here are those that look at caregiving. There are over 200 trials that have resulted in strategies, some of which now have been endorsed and are being implemented across agencies such as Indian Health Service and others, becoming increasingly available. So just as important as having rigorous trials to see what works to treat or prevent the appearance of dementias is to make sure we have just equally rigorous approaches to understanding what works to intervene for individuals and families under specific circumstances. Just to highlight some of the advantages, and these are just selective, what's happened since 2012 up through the present. In terms of underlying mechanisms, in 2012 we understood very little, or a handful of genes, for example, are known to be associated with early onset of Alzheimer's. There are now some 80 or more gene genetic regions that are either identified as risk or protective factors and help us to target new approaches. In terms of diagnosis, we were just beginning to see the ability to diagnose disease before death. Prior to these fairly recent years, Alzheimer's and related dementias were diagnosed at post-mortem only, and there were only clinical estimated or probabilistic diagnoses. By 2012, we were seeing the appearance of a PET scan to identify in the living brain the appearance of amyloid. This has now moved on to see PET scanning for amyloid, tau, newly appearing other molecules as well, and importantly, to identify blood biomarkers, which are less expensive, less invasive, and are important screens that are more available to individuals, not just for amyloid and taus. We're seeing them for more and more of the component etiologies of Alzheimer's. Disease-modifying therapies, well, there were none until these past couple of years when the first FDA-approved interventions occurred, these being monoclonal antibodies directed at amyloid. Clearly effective, repeatedly so. The beginning only, not the end. We need to be far more effective in identifying treatments and those who are going to profit from them most. Prevention, in 2012, actually up through 2016 and 17, when we addressed through the National Academy surveys where there were preventive strategies that were of adequate certainty and power to warrant public health campaigns, the answer was none. There were only some that were promising. Now we have seen extensive information showing the effectiveness of normalizing blood pressure in those with hypertension, and this is translated into an enormous public health campaign, not yet adequately implemented. We're seeing now the impact of strategies that look at multiple risk factors and interventions addressing them, so diet, exercise, cognitive training, and these are proving to be effective. We're seeing more and more suggesting that individual interventions are going to be effective, and over these next years, we're going to be approaching the time to implement these publicly. Similarly, for care and caregiving, I mentioned we have the first of these that are sufficiently documented and reproducible to be taken into widespread application. So current and future priorities, just point out in the sequence of summits that March 17th through 19th, this is going to be a virtual meeting. The 2026 Dementia Care and Caregiving Research Summits. Encourage you to participate, to register for this meeting. It'll give us a next iteration of updates on the progress in this field of research. We turned to the national academies recently to ask them to independently carry out a sense of what the priorities are for research towards interventions in Alzheimer's. They came through with a series of interventions that are now a part of the armamentarium being integrated into our milestones and strategies that I alluded to earlier in this conversation. And this is sort of a summary of what we've been talking about in terms of precision prevention and treatment. The entire patient population not so long ago was blind to us in terms of what was ongoing in terms of pathologies. As we've identified patients with characteristics that might have more amyloid or tau known and identified contributing pathologies, we now understand how heterogeneous the population is shown here, shown in these variations of colors. Right now, however, in the studies up to the present, we have largely been treating all individuals with a diagnosis of amyloid or amyloid-related dementias with relatively similar interventions. Our target, as we become more and more aware through biomarkers and understanding of the individuals, is to move to a state where individualizing, where for each individual at risk or with early stages of dementia, we're able to target just those processes which seem to be affecting that individual and are most likely to make a difference. You'll be hearing more about this in the talks to follow, and this is a part of the excitement that we share with you and look forward year by year at these meetings to hopefully present to you some of the progress that we are making. Resources, just want to emphasize again what resources we have available to the public. The Alzheimer's Disease Education and Referral Center, or DEAR, which is available on request by online or telephone or written requests, extensive information about Alzheimer's. Alzheimers.gov, another website that provides information on this as well. With all this, I thank you for the opportunity to take this time to give you this presentation, updating what's going on at NIH, and looking forward to years to come with your help and your input in documenting the progress that we all look forward to. Thank you.
Thank you, Dr. Hodis and Dr. Adams. We'll now turn it over to Dr. Valentina Mantua with the Food and Drug Administration.
Hello, everyone. I introduced myself before. I'm the Associate Director for Regulatory Science in the Office of Neuroscience and the Center for Drugs. Thank you, so that I can advance the slides, actually. And I will be speaking on behalf of the Food and Drug Administration. Since there's new council members, there's new federal partners today, I will start off by telling you a little bit of what the FDA does in this field, and I'd be very much appreciated if you could put up my slide number 2. I can advance and put up the slides as well. All right. Right, so in terms of how the Food and Drug Administration supports NAPA, now, first of all, in the first goal, prevent and effectively treat Alzheimer's disease and related dementia, we ensure rigorous evaluation of safety and efficacy of Alzheimer's disease therapeutics. We review clinical trials for both disease-modifying agents as well as symptomatic agents. These are those directed to other symptoms like behavioral symptoms or psychosis in the context of Alzheimer's disease. And also, we interact with sponsors and with the community through guidances, through regulatory advice on clinical trials, on the development of biomarkers. We qualify biomarkers because they can accelerate drug development. If we didn't have biomarkers, we would have gone anywhere in Alzheimer's disease. Under Goal 2, enhance care quality and efficiency, FDA contributes by helping making an earlier diagnosis and monitoring disease possible. We authorize diagnostic tools. We have helped the development of blood-based biomarkers that you've heard before from the NIA. We clear medical devices. We clear digital health technologies that assist with the capability of interacting with the cognitive problems that these patients have. We approve imaging agents to support clinical decision-making. And overall, our cross-cutting contributions include supporting innovation in the pre-competitive space and collaborate with sister agencies like the NIH, the NIA, I see there's CMS here, and other federal partners. Now, I'll tell you a little bit of what the progress has been in terms of the FDA contribution to NAPA since 2012, and I will start off with therapeutics. 2 milestones in the last few years reflect this progress. In 2023, we converted approval of lecanemab, an antibody directed against the amyloid in the brain, from accelerated approval to traditional approval. Traditional approval for us means that there's been actual benefit that has been observed in clinical trials, and now a patient feels, functions, and survives. In 2024, we approved donanemab, which is another monoclonal antibody for the treatment of adults with Alzheimer's disease. And I will not get into specifics of labeling of these 2 products, but we held an advisory committee, which is public live streaming, about donanemab in June 24. I want to say that these are landmarks. So we haven't had any therapeutic for Alzheimer's disease for a long time. And importantly, we have approved these drugs, as I said, by observing direct benefit for patients. It was very interesting when we held the advisory committee for donanemab. I don't know if any of you have seen it, to hear patients that were actually into the clinical trials that were treated with the drug telling us, well, I wasn't driving, and now, after 18 months, I'm able to go back into my car again. It was really moving. Now, I will move on to the imaging agents. The first imaging agents that we've approved between 2012 and 2014 were allowed us for the first time to actually visualize amyloid in the brain in vivo. That was unprecedented even at that time. Since then, in 2020, we have approved the first tau PET imaging agents that allows us to actually see also neurofibrillary tangles in the brain. These are the two main proteinopathies, even if you've heard just now that Alzheimer's disease has very complex pathologies. There are co-pathologies, but it was impossible to actually see the spreading of tau before. In 2025, we've updated the label of these tracers. Now, it may sound like only a regulatory action to you, but it was really important because we now allow these agents to actually tell us quantitatively how much of this protein there's in the brain. And that allows clinicians to select patients into clinical trials to understand if a drug works, actually clears out amyloid off the brain, and when to stop the treatment. And that is allowed by, an FDA label, which also, aids the work of the day-to-day work of the clinicians to get and select patients to get them into clinical trials. So really taken together, these therapeutic and imaging milestones support a more integrated pathology and treatment pathway, helping clinicians identify the appropriate patients and supporting responsible use of disease-modifying therapies that are now available. We'll now move to progress in diagnostics. As you've heard before, there's been traditionally very invasive diagnosis or very expensive on the other hand done, and now we're slowly moving into more accessible. In 2022, we have first approved the first CSF. So CSF is an acronym that stands for cerebro. A spinal fluid that requires a lumbar puncture. So initially, as for not having a PET scan, you still had to do a lumbar puncture to detect the presence of either amyloid beta or amyloid beta tau ratio into the CSF. Now, the first was approved in 22. In 2022, FDA also cleared another species of in vitro diagnostic and another one in 2023. These steps helped strengthen the diagnostic ecosystem beyond imaging, enabling validated laboratory approaches. However, we then moved to blood-based testing, which it was a significant step forward. Right now, in May 2025, Lumipulse phosphorylated tau position 2017 amyloid beta ratio became the first FDA-cleared blood-based test to aid diagnosis of Alzheimer's disease for individuals 55 and older. In October 25, we also approved the Accuracy's phosphorylated tau position 181 as a plasma test to be used in primary care. Now, how these two tests differ? Now, the first one rules in Alzheimer's disease, in that it is used in specialized care by neurologists. There's already a suspect of a diagnosis probable to be Alzheimer's disease. And with these tests, it's a confirmation that rules in the diagnosis. Now, the other test rules out the diagnosis, and it's mostly used in primary care settings in that it is a blood test that has a very high negative predictive value of 97%, in that if you have a negative test, you're 100% sure you don't have, or 95 or 97% sure you don't have Alzheimer's disease, and probably your symptoms are due to something else. So this is very important to have as in the armamentarium in primary care setting. I will really briefly show you what I think those approvals and those step forwards mean for the global community with Alzheimer's disease. Now, first, earlier, a more accessible detection of the disease. Over time, we've seen a shift from pathways that relied primarily on expensive PET scan or invasive CSF test to blood-based testing, which has the potential to make evaluation more accessible and to improve the appropriateness of use of drugs. And second, better patient selections for therapies. So the expansions of diagnostic capability reinforce the link between evidence of pathology and clinical diagnosis. And third, more treatment options for early Alzheimer's disease. Now, both the drugs that we've approved have been approved in a population with mild cognitive impairment or mild Alzheimer's disease relatively early in the process. And even in an early population, we were able to observe meaningful benefit in about a year and a half of trial. So in summary, FDA's contribution to NAPA are centered in enabling innovation and maintaining evidentiary standards needed for safe and effective use of drugs. Thank you.
Thank you so much. And we will now turn it over to the National Science Foundation. I believe Dr. Rebecca Farrell is joining us via Zoom.
Yes, I'm here. Good morning. Can you hear me okay?
Yes, thank you.
Great. I'm not sure if you can see me or not, but my name is Rebecca Farrell, and I'm here representing the U.S. National Science Foundation this morning at this important meeting of new and old partners. It's great to see and meet everyone, and thank you all for including NSF. I am a section head in the Social, Behavioral, and Economic Sciences Directorate at NSF, where I am the section head for Neuroscience, Cognitive, and Language Sciences. NSF has recently reorganized, and so this is one of the sections within SBE. My own background is that I'm a biological anthropologist with a broad interest in human aging and specific interest in female reproductive aging. I got my start in the federal government as a scientific review officer at the National Institute on Aging. And I am also a caregiver to my mother, who is living with Alzheimer's. Next slide, please. So the U.S. National Science Foundation is an independent federal agency, so we're not part of a particular department. And we support science and engineering across all 50 states and U.S. territories, and it's a very, very broad mission, science and engineering. We were established right after World War II to promote the progress of science, advance national health, prosperity, and welfare, secure the national defense. We do this by making grants primarily to universities and colleges, and our investments account for approximately 1/4 of federal support in basic science. But that's not all. We also support more solutions-oriented, sometimes called use-inspired or maybe even applied research with perhaps more immediate and observable advancements to the American people. So within NSF, we have 8 research directorates that focus on technology, innovation, and partnerships. That includes our small business and tech transfer programs, computer science, engineering, math and physical science, biology, geology, science and technology education, and my own directorate, social, behavioral, and economic sciences. I also would like to comment, because it will become clear why this is important in a future slide, the time scale of our investments is really broad. While some of our investments and impacts are quick to be realized in terms of specific research project outcomes, we also have impacts that represent decades of foundational discoveries that have led to major societal advances, including things like the internet and artificial intelligence. So what are we doing right now? It's an exciting time at NSF. We're focusing on several major cross-cutting initiatives, including artificial intelligence, quantum, biotechnology, and STEM workforce. That's science, technology, engineering, and mathematics workforce. And all of these areas, if you look at some of the details in my slide, you can see that they do have intersections with the goals of the group here today. Quantum is an underlying technology that's part of imaging tools. AI is everywhere, and surely is an important part of advances in our understanding and our treatment of Alzheimer's and related dementias. And biotechnology, also focusing on the basic science underlying things like amyloid protein and medical treatments. And then, of course, the STEM workforce, making sure that we are supporting the current and future workforce in both basic and applied research. So why are we here at this meeting? It's a very broad mission. It's a little bit different from many of the other federal agencies that are here today. So even though we have a broad mission, and given that our structure is really broad and focused on basic topical areas, we don't really have a portfolio or a program that focuses directly on Alzheimer's or related dementias, but we do have a distributed portfolio of relevant research. Since 2012, NSF has invested approximately $200 million in research relevant to Alzheimer's and related dementias, and you can see on the slide here that includes things in basic research, advancement of diagnostics and treatments. Some of those are actually our small business awardees. And then things perhaps related more to my directorate, improving quality of life. So understanding dynamics between caregivers and patients, and the nexus of those dynamics with technology aging in place, how we're using technology to improve the lives of caregivers and patients. I've listed a few recent examples. We have one from SPE that's about using language change as a diagnostic marker for Alzheimer's. We have something from our Technology Innovation and Partnerships Directorate using artificial intelligence to diagnose Alzheimer's. We have another program called Human-Centered Computing, where they're looking at smart objects as assistive technologies, and we have a program that NIH is part of called Smart and Connected Health, Personal Determinants of Health Enhanced Machine Learning Models for early prediction of Alzheimer's. So again, we don't have a program in it, but we do have a lot of fundamental and use-inspired research that's quite relevant to what's happening in this area. I would also like to mention that sometimes the folks who are getting the grants from NSF in these areas go on to be very successful in getting funding from other more mission-specific agencies like NSF. Lastly, I wanted to mention that NSF is very interested in developing partnerships not only with other agencies, but with public and private partners in ways that will help us amplify our investments in research and education and benefit society. I wanted to highlight one mechanism that's already in place at NSF that I believe it has so much potential for creating partnerships and amplifying NSF's impact. And this is a program called Intern, which is non-academic research internships for graduate students. This is a program which bridges the gap between our very broad research community focus and more targeted research applications by placing students of NSF grantees into non-academic internship opportunities. I don't think we've even started to utilize this mechanism as much as we could, and I see a lot of potential for this to be one mechanism for discussion as part of this larger group. I think there are a lot of students who are currently working in very fundamental research that might really benefit and also contribute to the goals of this group by being placed in some of those internships. So I look forward to continuing to discuss this and other opportunities. I'm sorry I can't be there in person today, and I thank you for your time.
Thank you, Rebecca. And now we will turn things over to Dr. Melissa Miller with the Department of War.
Thank you. Great. So my name is Melissa Miller. I'm the program manager for the Alzheimer's research program within the congressionally directed medical research programs within the Department of War. These are my disclosures. So I'll start off my presentation by introducing you, we'll go slow to go fast. I'll introduce you to the congressionally directed medical research programs, which I will henceforth promise to refer to as CDMRP. And as the CDMRP is an office within the Department of Defense, which I will henceforth refer to as the Department of War, or DOW. And CDMRP serves as the office that oversees appropriations for biomedical research programs that are directed to the organization by Congress, meaning that Congress names specific research areas and appropriates funds towards those research, towards research specific to those areas of interest. So thus, the overall aim of CDMRP is to transform healthcare through innovative and impactful research. And we do that through our mission to responsibly manage collaborative research that discovers, develops, and delivers healthcare solutions for service members, their families, veterans, and the American public. The chart on the right of this slide summarizes the who, what, where, why, and how of CDMRP. And of course, I don't have enough time. We don't have that 4-hour presentation to go over everything on this circle star graphic. But there are a few points that I would like to foot stomp for awareness. First of all, CDMRP was established in the early 90s as a direct result of grassroots patient advocacy, specifically advocacy for dedicated funds to support research to cure breast cancer. The unrelenting efforts of these advocates increased political awareness of health and healthcare-related issues, resulting in dedicated line item appropriations for biomedical research annually within the Defense Appropriations Act. And to be clear, the funds that CDMRP manages and receives are not included in the department's annual budget request or the president's budget. Rather, these funds are appropriated by Congress in addition to the core budget of the DOW. So hallmarks of CDMRP research programs include the fact that all research, all the funds are specifically targeted by Congress and added to the DOW budget on a yearly basis. The CDMRP specifically targets research according to each program area, and we fund projects that fill critical research gaps and address high priority needs. So because funds are appropriated to specific research topics, CDMRP programs are able to annually adapt our program's goals and investment strategies annually to be able to rapidly respond to the evolving needs of the field, as well as revised congressional intent for the programs. To this end, CDMRP leverages a 2-tier application review process, which means that we do not have a pay line, and applications that receive the highest scientific scores during that technical peer review are not automatically funded. Rather, applications are recommended for funding based on both their scientific merit as well as how well they address programmatic needs and our strategic priorities. Collaboration is another hallmark of all of our CDMRP programs. The success of CDMRP really is based on the unique partnership amongst Congress, the DOW, researchers, and consumers. Each partner plays an important and distinctive role in advancing military medicine and public health outcomes. As noted at the top of this slide, consumers, which we define as individuals living with the disease, injury, or condition, and in some cases, their care partners, are key contributors throughout CDMRP program processes. Consumers serve as full voting members on nearly all CDMRP peer and programmatic review panels, adding unique perspectives and a sense of urgency for our mission. Their participation ensures that the human dimensions of the target diseases, disorders, or injury are incorporated into the program's policies, investment strategies, and research priorities. Our programs also collaborate with our federal partners to ensure that the research supported across the federal and nonprofit space are complementary rather than duplicative. With the signing of the Consolidated Appropriations Act of 2026, which just happened, This law appropriated funds for the upcoming grant cycle. CDMRP will manage $1.27 billion of appropriations for 34 programs. This slide summarizes the appropriations for all CDMRP programs within the last 3 years. And apologies for the typo at the top right column that should say FY26, not FY25. And highlighted in yellow, which is almost impossible to see, I'm so sorry, is the appropriation for the Alzheimer's disease research program, which was consistently maintained at $15 million for all 3 years included on this table. You can also appreciate that other CDMRP programs were more significantly affected during the FY25 grant cycle. The CDMRP has developed and uses a common program management approaches, yet each program has individually tailored goals and a unique vision to enable it to meet the specialized needs of their research community and advocacy. All of that is to say that each of our programs will follow the process that is currently on this slide, but they will do so independent of one another. The efforts of one of our 34 programs does not necessarily dictate the efforts of any of the other programs. We are independent of one another. The first major milestone in this cycle, and the reason why I'm showing you this, is that we host annually a vision-setting meeting during which the program convenes a panel of experts, which may not be as robust as this one, but this panel contains expert scientists, clinicians, and importantly, consumers to assess the research landscape and develop an investment strategy that is implemented throughout the program cycle through our funding opportunities. As noted earlier, involvement of consumers and people with lived experience is a hallmark of the CDMRP process, and these key community members serve as full advisors across the CDMRP program cycle that I just showed. This slide highlights by the numbers just how many consumers and advocacy organizations help to inform and strengthen CDMRP's commitment to improve health care for our service members, their families, veterans, and the American public. Additionally, more and more CDMRP programs are requiring or encouraging consumers and people with lived experience to participate on research teams, thereby maximizing the potential impact of the research outcomes for end users. And at the vision setting meeting, the types of funding opportunities or award mechanisms that the programs will use to solicit will depend on the priorities and needs of those individual areas. There are numerous types of award mechanisms offered by CDMRP programs, and each of those are tailored to the particular goals of the program. Many funding opportunities span the research and development spectrum, while we have some award mechanisms that also support the training and mentoring of the next generation of scientists. So with that broad introduction to CDMRP out of the way, let's now focus on the efforts of the Alzheimer's research program. So this program was initiated by Congress in FY11, but CDMRP's management of those appropriations began in FY14. So to date, the program oversees roughly around $228 million in appropriations, and that number does include the $15 million to be executed in FY26. The vision of the program is to mitigate the impact of Alzheimer's and related dementias associated with TBI, military, and diverse risks, and the program delivers on that mission, or delivers on that vision through our mission to fund impactful, solution-oriented research to address critical needs and improve quality of life of service members, veterans, their families, and the public who are living with Alzheimer's disease and related dementia. This council is well aware, and we had an excellent overview of the scope of the AD-ADRD problem, so I'll forgo belaboring the statistics that are located in the middle of this slide, but I do want to highlight a few key considerations why Alzheimer's disease and related dementias have a unique relevance to military health and readiness for our warfighters. First, these statistics are highlighted in the yellow box on the right, is that individuals with a history of traumatic brain injury have a 70% increased risk of developing dementia. And remember that traumatic brain injury is widely considered the signature wound of the post-9/11 conflicts in Iraq and Afghanistan. However, the story doesn't end there, as veterans are 2 to 8 times more likely to develop dementia post-TBI than the general U.S. population, meaning that military service itself is a risk factor for dementia development. It's therefore incumbent upon us to better understand how other risk factors and military exposures contribute to dementia development and establish effective preventative measures. With that in mind, the program has established 5 strategic goals to drive innovation, fill research gaps, and address recognized risks within the field. And these goals are depicted within the pie chart on the left side of this slide. These goals focus on key areas of research, like understanding health disparities within ADRD, as well as understanding risk factors to reduce and prevent Alzheimer's disease and related dementias. We also have outcomes-focused goals, like improving the availability of early and accurate diagnosis and prognosis now, as well as increasing quality of life for people living with a dementia diagnosis. And finally, our last goal aims at addressing the issue of limited research capacity within critical areas of key importance to the program, which includes military health, women's health, and dementia care. To address these goals, the program solicits research through 3 funding opportunities targeted at transforming care, diagnosis, and research. Finally, all clinical research supported by the program must include a plan for collaboration with the affected community to strengthen impact of the research and ensure outcomes and measures are culturally acceptable. Key accomplishments toward the strategic goals of the program are included on the following slides. First, we have the clinical evaluation of the REACH HOPE intervention, which combines the REACH VA's behavioral education and support intervention, along with the Department of Defense's virtual HOPE box information and resources app. And together, these tools create a tailored telehealth intervention with one-on-one coaching and personalized digital support that leverages interventions with demonstrated success and efficacy in their target agencies. So the primary goal of this project is to establish a cross-agency intervention to reduce caregiver burden, depression, anxiety, while maximizing caregiver confidence. And this intervention will be so beneficial, particularly for service members who are adult child caregivers of individuals with dementia, many of whom are veterans themselves. In the area of diagnostics, the program has supported the development of a highly scalable and cost-effective home-based sampling and testing solution for early detection and monitoring of those blood-based biomarkers that we heard about earlier. The Griffin out-of-hospital sampling and testing systems, or GHOST for short, combines home-based finger prick blood collection with high-sensitivity immunoassays for time-based blood biomarker detection, which will greatly increase convenience for biomarker monitoring, not having to go into a separate place to receive those blood collections. The program has also supported research assessing dementia risk in veterans and examining racial disparities as they relate to vulnerability to AD. Together, these studies describe the interconnection of military risk factors, social determinants of health, and other environmental factors, sex, race, and ethnicity on the risk of dementia among older adults. Key findings supported that veterans living in neighborhoods categorized as disadvantaged by the Area Deprivation Index showed a significantly increased risk of developing Alzheimer's. Furthermore, vulnerability to hypertension was identified as the most powerful contributor to AD-ADRD risk in Black Americans versus white Americans. Additional research from these teams will support evaluating dementia risk for American Indian and Alaska Native populations with a history of military service. Importantly, this work will engage the American Indian and Native Alaskan communities for dissemination of results, recommendations, and community priorities for future interventions, ultimately aimed at reducing risk of developing ADRD or dementia for this population. And that is my last slide. Thank you very much.
Thank you so much, Melissa. And we're going to switch gears a little bit, shifting more to a clinical focus. So I'll turn things over to Dr. Sherry Lang with CMS.
Terrific, thank you. And again, it's a pleasure to meet all of the new members. If we could have the first slide, and given the limited time, I've included some of this important background information that you can go back. Oh, thank you. And review, but just to give you broad strokes as a reminder of CMS authorities and the scope and reach of the agency. So just briefly, CMS Centers for Medicare and Medicaid Services, there's only one M, although we have Medicare, Medicaid, and dual populations who we serve, as well as work through coverage through Marketplace. So CMS remains the largest payer for healthcare services globally, and the coverage has continued to expand over time with, by and large, serving older adults. 80% of Medicare beneficiaries are over the age of 65. That means also, though, that Medicare serves people who are under 65 who come into the benefit by way of disability, end-stage renal disease, and the like. So there are also individuals who age into Medicare as well as are dually eligible for both Medicare and Medicaid, which has some financial restrictions. And these are the numbers of the people who we serve across our programs. But importantly, I want to highlight this snapshot. This is a cross-sectional snapshot from our original Medicare program in 2023, just to delineate and explain the complexity of the population that is becoming increasingly complex over time. So the small arrow actually points to the line that represents those with a diagnosis of Alzheimer's disease and related disorders. What appears in the light blue, however, is the percentage of the population that has just dementia. And as you go more towards the right, we have people who have one or two other conditions displayed in yellow. The beige is 3 to 4 other conditions, and the darker blue is those in the population that have 5 or more conditions in addition to the diagnosis of dementia. So when we think of and implement the authorities, the statutory authorities vested in CMS and in Medicare, we think of the population of people who we're serving, many of whom either have or will develop dementia, but also have complexity because they actually are living with other conditions in addition to dementia. And this is just a laundry list, if you will, of some of the care. I will share, these slides are going to be publicly available. And happy to dive in and provide more information on anything that I mention here. These are just some of the services that are used by older adults that are helpful, that may be helpful to people living with dementia and also their caregivers. Being that CMS's primary role over time has been one of payer, we use the payer lens and authority to develop a cognitive assessment code that also requires care planning, and this code has been in use now. What it is intended to do is support a evaluation or a screening, if you will, including the use of a tool. We do not specify a specific tool, but in our rules often point to resources such as the NIH toolbox, because those resources are kept up to date. This is in addition to the annual wellness visit that is a preventive health services that also supports cognitive assessment of the entire individual with a preventive health authority, but does not require the use of a tool, because that preventive health visit is meant to capture all prevention relevant to the individual before the clinician. Being that CMS also has been moving away from a volume-delivered health system towards one that is more value-focused and value-based, we must also address quality of healthcare services, and therefore the development of quality measures that not only assess quality of care delivered to people living with a diagnosis of dementia, but also that would encourage earlier detection. So we've included these quality measures in our quality reporting programs for clinicians involved in the merit-based incentive program that incurs a financial incentive, if you will, whether it's a bonus, and currently if you don't report and participate in the program writ large, there's a financial penalty. I will flag there are two improvement opportunities that really point to activities that clinicians can engage that demonstrate improvement in their practice and how they identify cognitive impairment over time in the population they serve, and also help support them in delineating what their goals of care are and mapping out a care plan that is informed by those preferences and goals. I will say that it's difficult to delineate what happens in 2025 versus 2026. Some of this work has been ongoing over the years, but I will just mention a couple of things just to illustrate how CMS works. So supporting Goal 1, prevent and effectively treat Alzheimer's disease and related dementias by 2025. So we are continuing to work on this through our National Coverage Authority. Again, this is a statutory program that must serve Medicare beneficiaries and builds on the evidence that is developed and applied to these policies in support of the access to monoclonal antibodies. Several, as we've heard from Dr. Hodis and others this morning, by way of coverage with evidence development. And why that is a national coverage determination in and of itself, it is important because CED is utilized where there's evidence that's promising but not definitive as it applies to the Medicare population. So being able to match up what do Medicare beneficiaries look like, as exemplified by the graph I showed earlier, is important in providing the evidence to get to yes and full coverage. There have been 4 such studies approved. They are all continuing to accrue by including support of 2 registries that are growing over time. I will also mention, though, that in the Goal 2 support, enhancing care quality and efficiency, there are 2 notable actions that CMS has taken. One is the GUIDE model, Guiding an Improved Dementia Care Experience model by the Innovation Center, and I'll speak a little bit more about that, but also wanted to flag that CMS has a quality reporting program that incentivizes hospitals and other post-acute care providers to report on quality, and in the age-friendly major that is based on attestation that has been finalized and will continue in the quality reporting program for hospitals, that age-friendly measure includes encouragement of assessment of cognition, and in fact specifically mentions delirium, detection, screening, management, because that risk is so much higher in people who have dementia and also can result in long-standing cognitive impairment requiring additional care and services. So with regards to the guide model, the purpose of the guide model, and let me just pause to mention, the guide model was informed by a variety of additional model tests or pilots under the Healthcare Innovations Awards supported by the Innovation Center, but importantly built on the work that was done by our partners at NIH and also the Agency for Healthcare Research over time. This model really puts together coordinated care, so care coordination and management, caregiver support and education, and also respite services. So therein, meeting needs of what we have heard that both our people living with Alzheimer's and also their caregivers could really utilize this type of help. And over time, this program initially started out with those practices and systems that were accustomed to providing high-quality dementia care, but really started to encourage participation by new entries across the nation. We now can say we have models and participants, that is the providers of care and services, that serve beneficiaries and patients across all 50 states. They do so a little bit differently across the states, but the point is that it is available and it's being done, and we're learning a tremendous amount and expect to have quarterly reports that will be publicly available during 2026. With regards to supporting people who have long-term care and service needs, CMS continues to support the long-standing PACE efforts, Program for All-Inclusive Care for the Elderly, many of whom have cognitive impairment or dementia, and also by way of dementia being qualifying conditions for special needs plans, which CSNPs are part of the Medicare Advantage plan. And these, again, provide access to highly coordinated care and services. The links are as provided. Now, in looking forward, the guide model will continue, and remember that the guide model under the CMMI's authority must test care and payment models that will either improve quality of care, reduce costs, preferably both, and those are criteria required to scale. We're continuing with our work in the age-friendly space, supporting the development of additional quality measures for inpatient quality reporting, but also all 26 quality reporting programs that CMS has authority to support. Again, we are definitely learning and partnering across our federal family and also with our new members to use all the authorities that we have to really drive towards better care that really will deliver to better health outcomes that are meaningful for the people we serve. Again, really an honor, and we'll look forward to working with you all. Over.
Thank you. Thank you, everyone. Does everybody have all that? Got all that? That is a lot to digest, but it really leads me back while I was listening to our new federal agency partners and the existing partners that we have that have been here, is we're pivoting to early detection, early diagnosis, risk reduction, conversations that when I began in the Alzheimer's space, we really couldn't have. So the word that keeps bubbling up for me is hope. So I hope that you all are feeling very hopeful and engaged as we listen to our federal partners. It is so exciting to think about that. And I really invite all of you to consider signing up for the virtual summit. I think that will be very exciting. There'll be many more opportunities like that. And then I'm going to invite you also to do some Q&A. So while we're doing lunch, while we're breaking, and these federal agencies are here, and you have all of these lead experts around, for all of our new members, I just suggest you take some time, meet with some of these experts, get time to know them, exchange phone numbers. The networking, I think, will be incredibly important. So just a couple of housekeeping items. Again, thank you, and thank you to Secretary Kennedy. Thank you. I get to work really closely with Mary Lazare and other partners. Thank you to Cindy. Thank you to Helen. Thank you to Maria for helping stand up this meeting, and with government shutdowns and everything else going on. It was a long time coming, and I'm deeply, deeply appreciative of being here today. So just a couple of things. Federal members and members of the audience and others, we can get lunch at the 8th floor cafeteria or out at Potbelly nearby. If you leave the building, please make sure to take your ID because you'll need it when you get back through security. For us, the non-federal advisory council members will be doing a training in room 800. It's mandatory. It's an ethics training, so we will need to be there. But otherwise, we're just going to break for a bit. And like I said, please make the time useful for Q&A and just exchanging numbers and all the rest. Thank you so much.
Produced by the U.S. Department of Health and Human Services.